Hello, welcome to Stanford Care's monthly community health talk series, co-sponsored by Stanford Care, Stanford Health Library, and the Vincent V.C. Wu Memorial Foundation. My name is Joshua, and I am a first-year Stanford medical student. I'm very pleased to welcome Dr. Daniel Kim today, who will speak on overcoming barriers to better mental health in the older Asian community. And for context, mental health challenges often go under-recognized and undertreated in the Asian community, particularly among older adults. There's stigma, cultural beliefs, and limited access to care that continue to be significant barriers to both recognizing the symptoms and seeking treatment. So, this talk will explore the unique mental health needs of older Asian adults, examine the role of stigma in shaping attitudes towards mental illness, and highlight effective, culturally sensitive interventions that can support both individuals and the broader community. And so, join us tonight for a thoughtful discussion on how we can break down these barriers and promote better mental well being across generations. So, Dr. Daniel Kim is a board certified geriatric psychiatrist who completed a clinical fellowship in geriatric psychiatry in 2005, followed by an NRSA postdoctoral fellowship, both at the University of California, San Diego. He then served on the faculty of UCSD as medical director of the Senior Behavioral Health Intensive Outpatient Program, as well as associate medical director of the Senior Behavioral Health Inpatient Unit, until moving to Stanford in 2016, where he now serves as co-chief of the Geriatric Psychiatry Section in the Department of Psychiatry and medical director of the Inpatient Geriatric Psychiatry Service. In case you've come a bit later, we've recorded this session and we'll share the recording with you all. And during the talk, please submit your questions in the Q&A chat below. Around 7:45 p.m., we'll have a Q&A with Dr. Kim with questions both pre-submitted and those that you've submitted during this talk. And so with no further ado, please join me in welcoming Dr. Daniel Kim.
Thank you, Joshua, for that very lovely introduction. And I really appreciate this chance to discuss this very important topic with our community. So I'm going to start with just a review of the goals of this talk. As Joshua mentioned earlier, I'll first discuss some of the demographics of mental illness in the older adult Asian American community. I'll review some of the strengths as well as risks that are common in this population, and I'll discuss some targeted interventions for our population. Of course, I'll start with the requisite far side gallery cartoon. And I have to admit, this cartoon isn't as funny now as it was 10 years ago. It's like looking in a mirror sometimes. I can definitely empathize with wrinkles and loss of hair. And the reality, of course, is that getting older is never easy. And in addition to dealing with more physical ailments and health issues, we have more cognitive difficulties, emotional challenges. So it's not easy for any individual. But of course, the challenge is that it's not just one individual that's getting older. We as a society are increasingly aging. And in 2011, in particular, the first baby boomer crossed the threshold of the age of 65. And ever since then, we've been confronting what's been called the silver tsunami. And that's, been an increasingly challenging shift in our demographics. And back in 2020, older adults comprised 17% of the total US population. And that percentage is forecast to increase to about a quarter of the total US population in the year 2040. And it's challenging because in addition to, of course, being retired, older adults are generally the highest utilizers of healthcare services, particularly those who are very old, those above the age of 85. And it's something that we all are prepared for, but ultimately the real challenge is that there are not just increased healthcare costs, but there's an increased burden on those who are of working age and employed in providing the financial support for those older adults. What's particularly challenging is not just the growing number of people above the age of 65, and this is driven in part by not just the swell of baby boomers who have crossed that threshold, but also by the growing lifespan, the increased lifespan of all of us. But this is also met by another demographic shift, which is the steadily reduced childbirth, not just in this country, but across the world. And demographers forecast that by the year 2034, we're going to reach an inflection point. And after that year, the number of adults of the age of 65 will steadily outnumber those under the age of 18. And of course, it's challenging because that foretells a time when people who are of working age who are able to support us, not just financially, but also provide direct caregiver support, is going to be increasingly of limited supply. That point has already been crossed in other countries in Asia, in particular Japan, crossed that threshold in 1997. And ever since then, they have been confronting a real demographic dilemma. They are increasingly aging as a population, as a culture, and there are increasingly very few people to provide not just financial support, but direct caregiver support. And this is driven, again, in part by the increased lifespan, but also the reduced birth rate in Japan in particular. And of course, the Japanese, being the Japanese, have struggled to find different solutions, and they have come up with, in particular, a technological intervention. They have found that they have been putting a lot of time and money into investigating robotics to try to provide support for those who are older. And yet, of course, technology only can go so far in providing support for this kind of need. And unfortunately, this is a dilemma that still is seeking some support and solutions. So let me shift gears and talk about, of course, our unique population. And the challenge, of course, is that when we say that, when we talk about Asian Americans, we use that term as if it's a monolithic group, but the reality, as we all know, is it's an extremely heterogeneous group. And the term Asian Americans covers 50 plus unique ethnic groups, at least 100 plus unique languages and dialects. And ultimately, we can talk about 80% of Asian Americans coming from 6 specific groups, namely the Chinese, Indians, Filipinos, Vietnamese, Korean, and Japanese. But of course, we all have our unique culture and identity, and heaven forbid that anyone misidentify a Korean as a Japanese. I mean, we all have different histories that play into our unique life experience in the States. And the Amazing American community is increasingly becoming a dominant ethnic group in the U.S. It is the fastest growing ethnicity in the U.S. There are going to be about 5 million older Asian Americans by the year 2040. And by that year, they'll comprise about 35% of this demographic group. And they're forecast to surpass the Latino community as the largest older immigrant group in the year 2055. And the real challenge is that, of course, there are cultural and linguistic challenges that this group has to face. And in particular, Asian Americans have a significantly high percentage of people who speak limited to no English. About 60% of Asian Americans speak limited English. And of course, that causes some significant acculturation stresses. When someone immigrates to the U.S., they of course not only have the stress of transitioning or changing their country, but they have the loss of community. They have, again, significant language and communication barriers. They have significant financial and occupational pressures. And many people from different countries come to this country with significant traumas in the past, in particular those who come from war-torn areas. And finally, and most challengingly, perhaps here in the country, even now, particularly now, perhaps there is significant racism and discrimination that our older adult patriots have to face. So it's interesting though. If you look at the demographics of depression in older Asian Americans, there is a varying rate of depression depending on the group that you're looking to. The Vietnamese community experiences about 17.6% rates of depression, and it goes down there to the Japanese community, which has a rate of depression of about 6%. And that's compared to other ethnic groups. The Hispanic community has a rate of depression of about 16%, as does the Black community, whereas the non-Hispanic white community has a rate of depression of about 9%. So it's interesting that despite the stress of acculturation, despite the challenges of communication, that the rates of depression are not significantly higher than what they are. Yet despite that, the challenges of depression are, of course, real. And in particular, older Asian Americans have consistently the highest rates of suicidal thoughts, about 60% versus the rates of suicide in whites of about 40%, and in Hispanics of about 40%, and Blacks about 27%. Furthermore, older Asian women in particular have the highest rate of suicide amongst other women, about 6.5 deaths per 100,000. I'm going to shift gears again and talk about something called a happiness index, which you may have seen in the news since they just recently released their latest rating. And this has been, they've been doing this, the UN has been doing this for about, I think, 30 plus years. And almost invariably, the top scorers are the Scandinavian countries. And of course, I always wonder, what are the Scandinavian countries doing right that the rest of the world is not? And I always, of course, want to visit Scandinavia and see what it's like and see whether happiness is as truly high there as it is said to be. Of course, the question begs itself, how do they rate or how do they determine happiness in any given country? And it's based on a variety of demographic factors, but it's primarily self-rated. So they ask citizens of these countries to rate their happiness from 0 to 10, where 0 is feeling notably unhappy and 10 is extremely unhappy or extremely happy. And Finland and Denmark usually rate their happiness around 7 or 8, is my understanding. And you compare that to Asian countries, and none of them really have crossed the 25 threshold. Taiwan's the highest at 27th in ranking. And then there's Japan at 55, South Korea at 58, and then India comes up lowest at 118th. And I think we can perhaps argue that perhaps the Asian countries are just more realistic about happiness. I think many of us, I don't know when I would ever rate my happiness at a 6 or 7. I think on most Mondays it's at most a 5 or 6. But the real challenge is that regardless, across the years, Asian countries have historically rated their life satisfaction and happiness as significantly below Western countries. And yet, if you look at the rates of depression and anxiety, those rates are consistently lower in Asian countries versus Western countries. So the lifetime prevalence of depression in France is about 16%, Italy 12%, and then so on and so forth. And in Korea, it's 2.9%, and Taiwan is 1.5%. Why, despite the lack of happiness, does the rate of depression not, why is the rate of happiness not reflected in the rates of depression? One question. So the first question is this a real difference? Are people, are we accurately diagnosing or defining anxiety and depression in these countries? And one argument is that maybe our method for diagnosing depression is culturally sort of obtuse. We're not asking the right questions for different cultures, is a thought. Of course, the DSM, the sort of the Bible that diagnoses mental illnesses in the West, has a very specific criteria and set of symptoms that are commonly associated with depression. Maybe those criteria are not appropriate or are not culturally specific for Asian countries. And in particular, we know that Asian countries, when someone has depression, quite often the symptoms that they focus on are somatic complaints rather than the affective complaints that are, of course, more commonly endorsed in the West. Of course, the challenge with that is that even though people in Asia who have depression may emphasize somatic symptoms more than affective symptoms, nonetheless, affective symptoms are present. So the next possibility is maybe Asians are less willing to recognize depression. Maybe the stigma associated with mental illness precludes them from admitting to or recognizing the symptoms of depression. And that's valid. We know that there is a pronounced stigma associated with mental illness writ large in Asian countries. And yet, if you look at our ability to make other diagnoses of serious mental illness, those rates are similar across the board. For example, if you look at the rates of bipolar disorder across Asia as well as Europe and America, those rates are pretty similar. And also, if you look at rates of schizophrenia, the rates of recognized schizophrenia are pretty similar across Asia and the rest of the world. So the stigma doesn't seem to be true across the board when it comes to mental illness. And finally, potentially, do Asian countries have some protective factors that are sort of part of their culture, part of their philosophy, maybe even part of their language that somehow protect against depression? I don't know the answer to that question, and yet it provokes some questions. And there is a lot of speculation that maybe the sort of holistic philosophy that is more common in Asian countries may be protective against the worst of anxiety and depression. Maybe even the language that we speak in Asia, language that focuses on morphemes rather than phonemes may, to some degree, provide some protection. And that thought is in part provoked by neuropsychological tests that show that people who speak, in particular Mandarin, may have more of a cognitive reserve than people who speak phonetic languages. Again, this is in large part speculation, but it does provoke some questions. I'm going to shift gears again and talk about schizophrenia. Again, as I mentioned earlier, the incidence is pretty consistent throughout the world. About 1% of the world's population develops schizophrenia over their lifespan. And it is significantly expensive and costly illness. In the US in particular, it costs about $342 billion or cost about $342 billion in 2019. And this measures both the direct costs of care, of treatment, and often institutionalization, as well as the indirect cost of loss of productivity from both the patient as well as caregivers for the patient. So it's a real challenge, and it ultimately is one of the key drivers for healthcare costs in mental illness. So back in the 1970s, the WHO did a seminal study looking at sort of cross-cultural psychiatry, and it in particular was looking at the both the rates of depression, or rates of schizophrenia rather, as well as the outcomes. And they found something quite interesting and almost paradoxical. They found that many patients in so-called developing countries, and in particular, they looked at patients in India, Colombia, and Nigeria, had significantly better outcomes, both clinical as well as functional outcomes, than people with schizophrenia in so-called developed countries, namely Europe, US, and Taiwan. And initially, when the study first came out, the thought was they were, there's a selection bias. They're finding people who are going to do better and following them. But these results have been replicated in multiple subsequent follow-up studies, not as robustly, but still in a way that shows that this is a real finding. That, again, for some inexplicable reason, people who are people with schizophrenia in third world countries do better. Why is that? Why do patients in a country where there's less money, less resources, less clinical care, doing better than people who with schizophrenia in the first world country? And there's a lot of ideas about why that is, a lot of speculation. But it's hard to know for sure. But the hypotheses have been that people in developing countries have more family support. They live in a larger family community. They have more integration into their society, and potentially they have less stresses. Growing up in an agrarian community may be less stressful than growing up or living in an industrialized, urbanized community. And of course, along with that come potentially decreased functional stresses and decreased social stresses. And finally, there's some thought that this may be a function of these societies having less expressed emotions, less hostility, less expressed emotions in general. But all that may play a role. One hypothesis that was initially brought up was maybe people in these countries do better because they're not being treated. Maybe our treatments in the first world are actually doing harm. But that question has been investigated, and the reality is that people in the third world countries who were getting treatment did better than people who were not being treated. So it's not the treatment itself that's the causative factor in the better prognosis. But it raises some questions. And I'm going to shift gears again and talk about another issue that's, of course, common with aging, and that is cognitive impairment. And I think, that's probably the fear that most of us have when it comes to getting older. And for most of us, it's not just the wrinkles or the loss of strength or loss in mobility. The issue that's common with aging that I'm most afraid of is dementia, losing our memories, losing our sense of personhood. And it's a real fear because in many respects, cognitive impairment is a function of age. We know that when we're at the age of 60, there's about a 4% chance that we'll have some cognitive impairment, and that risk essentially doubles every 5 years afterward. So by the time that you're at the age of 85, you have about a 1 in 3 chance of having significant cognitive impairment. But if it were just having cognitive difficulties, I don't think any of us would really care that much. If my mom needed help finding her purse, or my dad needed help finding his wallet, and I needed to be there on a regular basis to help them figure out what's going on or help them with their functional needs, I think any of us would be happy to do that. The real challenge becomes when mom and dad start having behavioral changes, when they start accusing you of stealing from them or start wandering in the middle of the night, when they start becoming agitated and paranoid. That's when most of us would find this illness challenging. And it's a real dilemma because these behavioral issues are the rule in dementia. They're not the exception. As this kind of busy slide shows, about 80% of people at the time of the diagnosis of dementia present with marked agitation. And what's even more interesting is that people with this illness have symptoms of behavioral changes that precede the time of diagnosis by up to 40 months. So, dementia is an illness of behavioral changes, not really of cognition, although cognition, of course, is the primary factor that is necessary for making the diagnosis. And what are the consequences of behavioral symptoms of dementia for us? Well, it's, not only do people with these symptoms have worse quality of life, but they have significant impairment in daily functioning. And of course, these behaviors impose significant caregiver burdens. In fact, the rate of depression amongst caregivers is astronomical. In addition, it's the behavioral issues that are generally the primary reason why patients with dementia are institutionalized. Again, it's, if mom and dad were just having difficulties with remembering where things were, we'd be happy to keep them at home. It's, again, when mom and dad are wandering in the middle of the night, having difficulty taking medications from you, that we find that we need to have them in a safer, more appropriate place. Of course, institutionalization has significant financial costs associated with it. And finally, there are real health consequences to untreated behavioral issues. They have worsening prognosis in terms of dementia progression, and they ultimately have accelerated mortality. Now, these issues are uniquely challenging, I think, in the Asian community. First, because of the stigma that's commonly associated with behavioral changes regardless, patients with dementia often delay evaluation and subsequent diagnosis of the illness and have subsequent reduced healthcare access. They don't seek care because of the stigma that the behavior imposes. In addition, many family members struggle with trying to manage a loved one's behaviors. I think our respect for our elders keeps us from taking the steps necessary to limit their potentially dangerous actions. And the real challenge then becomes that these behaviors impose a significant burden on families. And I'm well aware that when I talk about families being the caregivers for older family members with dementia, I'm primarily talking about the women in the family, because it's generally the women who shoulder the brunt of these responsibilities. Well over 80 to 90% of caregivers are the women of the family, particularly in Asian communities, I'd say. And again, the risk of caregiver burnout is astronomical. It is huge, and it is unrecognized all too often. And the dilemma is that this unrecognized issue leads not just to health issues for the caregiver, but it frankly also affects the person with dementia, because when the loved one is unable to care for them, then their health is going to suffer as well. How do you manage this? I mean, ultimately, the management depends on a couple steps or a couple prongs of care. Medications are often tried, but the reality is that the first thing to try is looking to see what we can do in the environment, looking to see what we can do that doesn't depend on medications, because the reality is that all of our medications have potential side effects that could be challenging. But the very first thing to do is to look for other medical causes for the changes in behavior, because all too often that's unrecognized. When someone has a diagnosis of dementia, the maybe understandable temptation is to dismiss any behavioral changes to the dementia, when the reality is that having a dementia significantly increases the likelihood that there are other unrecognized medical issues that might be driving the behavioral change. Even something as simple as a urinary tract infection can cause an outsized significant change in behavior. And that's not to, and there are other things, of course. Pain is often unrecognized. If someone has a dementia, they often have impairment in their language, so describing their discomfort may be challenging, and that can often be a significant driver for agitation and aggression, and similarly constipation. When I'm working, I think the residents often accuse me of having this prurient curiosity about bowel movements, but the reality is that unrecognized constipation can be a huge driver of behavioral changes. And then, when someone is having cognitive impairment, they're not able to sort of self-regulate or change their environment. So quite often they're overstimulated. They're in a situation that is too much for them to process. That can cause agitation. Or similarly, they may be understimulated. They may be bored, and they may seek activities that cause challenges to their behavior. So the real first step in managing these challenges is first to try to provide some structure to the environment. Trying to have it not too overstimulated, but not too understimulated. And then you want to try to provide a scheduled, consistent routine through their day. And ultimately, it's those kinds of interventions, trying to tailor the support to where they are, to what they need, that is the most effective way of managing these behavioral issues. And the real dilemma is that there's no recipe for any of this. You can't just prescribe a pill and say, this is what you do. You have to know the person who's having these changes in behavior, be able to identify what might be driving the changes, whether it's pain or overstimulation or what have you, and find interventions that are palatable, that are acceptable to the person who's experiencing the dementia. When someone, for example, when we often get older women who have changes, and one tool that I have found helpful on the inpatient unit is to give them a basket full of unfolded dish towels. And you say, Margaret, I have this basket of dish towels. Can you fold them? And you give it to them, and they spend a happy hour or so folding the dish towels. And then you, of course, take it away, say thank you, go around the corner, pick it up, and then 20 minutes later, come back and say, Margaret, I have this basket full of dish towels. Can you help me with that? And finding, of course, if I were the one with dementia, I probably wouldn't find that as stimulating, or maybe I would. But the key is to find the activity that is targeting where they are and help them to keep their days occupied as a result. But everyone's a little different, of course, so that's why it takes time and effort and, frankly, a lot of experience to find the intervention that's most helpful for any given person. No, of course, at some point, medications may be necessary, not just for helping someone with dementia, but for depression. And yet, we know that older Asians in general do have unique metabolisms that make using traditional medications potentially more challenging. And in particular, many of the medications we use for treating depression, anxiety, or psychosis are metabolized differently in Asians versus other ethnicities. And I've listed a number of enzymes that are in the liver that metabolize many of the medications they use. And the challenge is it's hard to know for sure whether we have these mutations or not. And ultimately, it's often necessary just to try and see whether medications are tolerable or effective or not. Our mantra in general in geriatric medicine is to start low and go slow. And that's particularly true for the older Asian person, because again, not only do they have the challenges of a slowing metabolism from later life, but again, the Asian genetics may be also challenging. So there are a number of methods to look at whether any given person has these mutations, and the two main vendors of this genetic testing are GeneSight and Genomind. And typically, genetic testing is covered by Medicare when it comes to these kind of questions. Along with that comes other significant risks, not just of poor tolerance, but in particular with antipsychotics, there's a risk of what we call EPS, or extrapyramidal symptoms, and those are essentially involuntary motor movements that are associated with this class of drugs. And it's one where people may have stiffness, muscle tics, and ultimately, if these symptoms persist, they may become a permanent condition called tardive dyskinesia. And the challenge is that once tardive dyskinesia is in place, it's particularly entrenched. There are some treatments, but all too often they are forever left with this, functionally limiting and stigmatizing condition. So, what other non-pharmacological interventions are potentially helpful for dementia in particular? Well, we know that aerobic exercise alone reduces the risk of dementia significantly by about 28%, primarily through reducing the cardiovascular risks. Is Tai Chi better than just regular exercise? Well, there's actually a number of studies that's showing that it is. There's a pretty good meta-analysis that came out, I think, 10 years ago that showed that in normal controls, Tai Chi can significantly improve executive functioning in particular compared to no exercise. And even if you did exercise, there is still significant improvement in executive functioning compared to just your regular activities. This is still true even when someone is already cognitively impaired. There has been demonstrated to be small but still significantly statistically significant improvement in cognitive scores as well as functional status with regular use of Tai Chi. And that's been also shown to be helpful for anxiety and depression. And there's also biological markers that are known to be decreased when Tai Chi is practiced routinely. This is also true for yoga. There's, again, also multiple studies showing that yoga has improvements in attention and memory and executive functioning, and also significantly reduces anxiety and depression. Ultimately, of course, these are mediated by not just the physical effects, but arguably from the mental effects of these practices. Again, the benefit of yoga and Tai Chi are significantly better than through just regular aerobic exercise. I'm going to highlight something else that arguably is something that is more present in Asian communities versus non-Asian communities or white communities in particular. And we know that Asian Americans, about 24% of Asian Americans live in intergenerational housing versus 13% of white households. And that has a real impact as well. There's, of course, the obvious financial advantages, and that's been demonstrated in multiple studies. The rate of poverty is significantly decreased if someone lives in an intergenerational house. And there's also subsequent improvement in socioeconomic status. But there's also clear social advantages. There's studies showing that having a grandparent in the household significantly improves academic performance in the grandchildren. And of course, having the wisdom of our elders in the household directly giving advice is unmeasurable. And finally, of course, having built-in babysitting services is a huge advantage, without a doubt. But in addition, there's, of course, psychological advantages to having intergenerational housing. There's reduced loneliness, there's increased emotional support, and there's also been amply demonstrated decreased rates of anxiety and depression when someone lives with multiple generations in the same household. So what are some of the barriers to care? Ultimately, again, we identified language as being a significant barrier to Asian Americans getting mental health services. And we know that counties that do provide interpreter services have a significantly higher rate of utilization of services. Now, that's not to say that family presence and often interpreter support isn't helpful as well, but the reality is that depending on families to provide interpreter services is a practice that's fraught with danger. Ultimately, we do want collateral information from family members, but having a family member present when the person in question is potentially discussing very private, intimate details about their illness or life experiences is one that's dangerous and ultimately likely to cause difficulties in getting the full range of information that's necessary for optimal care. in addition, of course, another barrier is the frank stigma that is associated with mental illness in this population. And, the challenge is made even more fraught by a lot of the labels that many Asian communities have when it comes to various mental illnesses. They often use terms like crazy or stupid when it comes to describing, say, dementia or other psychiatric illnesses. And there's been clear studies showing that national attempts to relabel these mental illnesses using less pejorative labels can lead to increased diagnoses and improved engagement in care. And finally, at least in the US, having culturally sensitive and educated community resources is of immense benefit when it comes to engaging these patients in the necessary services. So what do we as a society need to do? First, I think having the ability to provide care to our patients in the language of their choice is crucial. Ultimately, it's crucial not just to improve the diagnosis itself, it's crucial to provide the necessary information that they may otherwise lack. And finally, it's important to get the patient to continue the care that's often necessary for them to have optimal response. But that's on one side. The other side is we as a provider need to be more aware of the nuances when it comes to the patient's lives. And there's a phenomenal book that many of you probably read already called The Spirit Catches You and You Fall Down. And this describes the unfortunate clinical experience of a Hmong child with epilepsy who had suboptimal care, not through anyone's fault, but because of this cultural misunderstanding between the patient and her family and the well-meaning providers who just didn't appreciate or understand the cultural differences between them and the patient. Ultimately, there's a lot of challenges that I think we need to overcome as a society. We need to provide care in places where the patient feels welcome and frankly is just able to get to, because all too often there are logistical hurdles to getting the care that they need. And of course, the dilemma is I have also been falling into the habit of talking about Asians as if they're a monolithic group. They're not, of course. There's a whole swath of different ethnic groups within the term Asian Americans. And we have to be aware that, again, they each have their unique cultural background and nuances that we have to be aware of in order to provide appropriate care. So we need to do more research on this as a topic. I'm going to end with a number of community resources that could be helpful for folks in the Bay Area. And the last item, last but not least, is the Stanford SMART Clinic, which stands for Stanford Mental Health for Asians Research and Training. And it's a clinic run by Rona Hu, my wonderful colleague, and it provides mental health care with a variety of Asian languages, with both social work support as well as psychological support. And it's a phenomenal resource to have. They're doing a lot of not just clinical work, but research in this area. So definitely a resource to explore. And I'm going to end there. Definitely appreciate this chance to share my thoughts.
Thank you so much, Dr. Kim. That was a wonderful talk. And we're now going to transition into the Q&A session. So first of all, you mentioned cultural stigma and differing views on depression and anxiety in Asian cultures. And so how should clinicians and families approach older Asian adults who are reluctant to receive therapy?
Well, first of all, it's a very common challenge, not just among Asians, but for many older adults. And the dilemma is, I think many older adults find, again, not just the diagnosis stigmatizing, but find that they're alone, that they feel that they're alone in this illness. I think the first step for all clinicians is to normalize the experience that they're having. And of course, when we're in the midst of this illness, we feel alone. We feel like this is an experience that's uniquely ours, and yet it is something that is universal, of course. And recognizing that universality, I think, is the first and crucial step for them to accept the potential solution to their experience. And of course, then it becomes necessary for them to get care that can appreciate their situation, can understand their social and community background. And that's where it becomes challenging because, of course, all too often there aren't many community resources that can provide culturally sensitive, targeted care for our loved ones.
Mm. And a guest asked about the lower happiness that you see in Asian Americans, but also the paradoxically lower anxiety and depression rates. And so one of the audience members was wondering if that was due to humility or if you think there was something else at play that's contributing to these rates that you mentioned.
That's a good question. I certainly suspect that maybe Asians in general are less prone to sort of focus on individual accomplishments. I think they often see themselves more in the context of their community, and that may have some impact on their appreciation or sort of evaluation of any given happiness index. I also think that, again, perhaps there is a philosophical stance that may contribute to not just an under recognition of happiness, but an under recognition or under sort of awareness of depression. And I think, again, this may relate to the sense of, we as individuals in a larger context, a more holistic approach to our lives, and that may give us more appreciation of the nuances that, being aware that we're more than just someone who's happy or depressed. We have other values as well beyond those sort of emotional states.
Mm-hmm.
That's speculation, to be honest.
That's great. Thank you. And another audience member wanted to hear a bit more about the strengths of Asian community in dementia management in order so that we can enhance these unique positive aspects in our communities. So you mentioned Tai Chi, and you also mentioned intergenerational housing. Someone was also interested in daily religious rituals, and that can potentially reduce behavioral problems. Wondering, maybe what are your thoughts on religion and other potential strengths of the Asian community in dementia management?
Absolutely. I know that in many Asian communities, the church is the community center for a lot of us, and that, without a doubt, has significant strengths associated with it. In addition, there's been many studies showing that religion in general provides a source of solace and help is associated with decreased rates of anxiety and depression. And I'm sure also contributes to reduced behavioral issues, not just through the actual beliefs itself, but also because belonging to a strong community is critical in having better outcomes in not just dementia, but in most mental health illnesses.
Yeah, that's great. And when it comes to preventing dementia versus kind of when dementia has already been its onset and kind of slowing the progression of that, do you see those interventions being very different, or do you think those are pretty similar in terms of those interventions?
Well, I think the interventions are universal, but hopefully Asian community is uniquely situated to take advantage of some of these interventions. In particular, again, engagement in a community is crucial. We know that social interactions are strongly associated with better outcomes when it comes to dementia and potentially reduced incidence of dementia. Again, social interactions where you're engaged in active physical as well as social discussions is well regarded as a treatment or an intervention for reducing the risk of dementia.
Mm.
And also, again, as I mentioned earlier, Tai Chi and yoga, those are not just great forms of physical exercise, but they do provide, sense of calm. They are the meditative aspect to these practices can't be undersold. They're undoubtedly a critical part of why these practices have more benefit than just straightforward aerobic exercise.
Great. And another audience member was asking about if there's a difference in attitudes towards kind of the care towards older Asian Americans, whether it's from first generation immigrants versus those who are more culturally adjusted to our society and beliefs. Is there any differences in the caregiving and the cultural attitudes towards caring for those older Asian Americans?
I do suspect that as Asians become acculturated to Western societies, that it may impact different practices that are adaptive or reduce the risk of mental illnesses. In particular, veneration of the elders, for example, may be a practice that is less prominent in younger generations. And yet, of course, I think there is real value to that. Not just because of the benefits of living intergenerationally, but the reality is that people who have successfully aged have real wisdom that they bring to the table. That's not to be overlooked at all. And it would be a shame, of course, if that was the case.
Yeah. And given that older Asian American women have the highest suicide rates among women, what do you think are the most urgent cultural or structural barriers that we need to address?
Good question. I mean, I think one likely stressor that is, most often imposed on Asian women is the caregiver burden. I mentioned earlier that the rates of depression amongst caregivers is huge and all too often overlooked. I think the first key is recognizing that this burden that all too often is shouldered exclusively by the women in our families, recognizing and hopefully doing something about it. Maybe taking, we men have to take more ownership of this responsibility. And it's been frankly easy for us, arguably, to just let it fall on the women in the family. And ultimately, this is something that has to be changed. We as a society, we as a culture have to change this. And it may be a cultural thing, but it's a cultural factor that is not serving us well.
Mm. And you mentioned the risks of psychotropic medications in older Asian patients. And so, what are some of your guiding principles for prescribing or deprescribing in this population?
Good question. Ultimately, again, the practice would be the mantra that I mentioned earlier, which is to start low and go slow. But I think we have to be very wary about antipsychotics in particular, because we know that this population may be uniquely sensitive to antipsychotics. With that said, there are times when antipsychotics are needed for a variety of mental illnesses. So, we want to use these medications judiciously, I guess is the bottom line. And ultimately, just continue to be mindful of the potential risks and monitoring closely and using carefully and being quick to reduce and stop medications when it's clear that they're having side effects.
Mm-hmm. And do you think we're curious about the role that like long-term care insurance purchasing decisions might have on caregiving? So is it possible that the Asian American community can have lower rates of purchasing like this long-term care insurance, and can that lead to a feeling of more responsibility to care for the elders?
Well, I'll say that the rate of long-term care insurance purchase is significantly lower than it used to be, and it's largely driven by the market. Insurance companies have recognized that long-term care insurance is going to be increasingly expensive, and consequently, many of them have led the market or priced it to a point where it's hard for many people to purchase. And yet, it is, if you do have it, it's a good resource to have. And I think many Asian communities have, understandably perhaps, felt that it's not needed because they, like many families, turn to loved ones for care. I feel like I'm not answering the question. Ultimately, I think if you're able to get mental long-term care insurance, it is something that would arguably be well worth the investment. But it's the challenge is that insurance companies are also aware of that and are pricing accordingly.
Right. And what advice do you have for caregivers of older Asian adults who are experiencing behavioral symptoms of dementia, particularly when there are these cultural expectations like filial piety that limit their ability to seek outside help?
Yeah, that's a real dilemma. I mean, ultimately, we want to respect our loved ones, but I think it's also important for us, the loved ones, to recognize that this is a psychiatric illness that is affecting their ability to make cogent decisions. And, it's a challenge to separate that historic respect we have for our loved ones and being willing to supersede their expressed wishes. And we would only do so knowing that we are doing so in their best interest, of course.
Mhm.
It's a
Yeah.
dilemma. Yeah.
Thank you. And an audience member had a question about like types of ideations that may harm Asians as opposed to like other groups. So many with mental illness in Western society focus on like God, as God told me not to take meds or to hurt someone, etc. Are Asians focused on these same ideologies that may harm themselves or others, or is there a different ideology there?
That's a good question. And I don't know the answer to that. I know many Asian communities do believe in the sort of in the Christian God and belong to a Christian faith. So I don't know whether that's uniquely Western or in European cultures. I think that may be buffered by again the our being embedded in a larger community, having a greater sense of individual as being part of a larger whole. And I think that arguably has a lot of protective factors associated with in bleeding.
Great. And our final question of the night, how do you help older Asian adults with dementia maintain a sense of purpose and structure in their day, especially when memory and attention are impaired? I remember you mentioned this anecdote of, the towels and things like that. Do you have any other strategies to help them maintain a sense of purpose and structure?
I think having a sense of purpose and value and service is crucial for successful aging. I think we all value the sense of having an identity where we are able to give to the larger whole, to our community. And, I think even with dementia, people can still can still be a vital part of our family, our community, our society. And helping, again, that's why continue to live within our group, our community is crucial. Still having that sense of identity, and you may lose it. The sort of the awareness of it may be lost to sort of an external degree, but you are, I think, still instinctually aware of your community, even when you have more pronounced dementia. You still have you're able to maintain some semblance of a memory when it comes to that connection, I think. At least that's a hope. And ultimately, by keeping things familiar, by keeping them embedded within the community, we can do much to stave off the worst of this terrible illness.
Thank you so much, Dr. Kim, about bringing to light these issues and also the hope for interventions for kind of bringing more awareness about this caregiving and the disparities that exist in mental health among older age Americans. Really appreciate your time, Dr. Kim, and thank you all for coming today. In case you have any questions that we didn't get to, please email Stanford Care at stanfordcare@stanford.edu, and we will send your questions to Dr. Kim. Have a wonderful night, everyone.
Yeah.